All right, welcome to The Explainer. Today, we're jumping straight into a really fascinating clinical journey, one of those real-life medical mysteries. As clinicians, we're constantly seeing conditions that look straightforward in a textbook, but then they present in just the most extraordinary ways in actual human beings. Today, we are shining a spotlight on a rare, completely captivating pathology of the ear. So grab your coffee, get focused, and let's unravel this thing together.
Imagine this for a second. You're trying to go to sleep, right? But instead of quiet, there's this constant rhythmic whoosh, whoosh, whoosh right inside your head. And it's perfectly synced up with your pulse. This isn't just mildly annoying. It's a highly visceral, incredibly distressing human experience that we call pulsatile tinnitus. And when a patient is sitting right there in your clinic describing this kind of biological alarm clock, there's one specific, fascinating culprit that needs to immediately jump to the top of your differential diagnosis.
And that culprit is the glomus tumor, also known as a paraganglioma. Now, take a close look at this definition. See the word benign in there? That usually makes patients breathe a huge sigh of relief. But, as we know in the medical world, benign just means it doesn't metastasize all over the body like a typical cancer. Think of a glomus tumor kind of like a dandelion growing in a crack in your driveway. Sure, it's just a weed. It's not going to take over the entire neighborhood, but it is locally aggressive. If you leave it unchecked, its highly vascular roots are going to slowly, methodically expand, and they will destroy the surrounding bone, the nerves, and the delicate little structures of the middle ear.
Okay, let's dive right into this. Here is our roadmap for today. 1. What is a glomus tumor? 2. Spotting the reddish-blue mass. 3. Mapping the tumor's spread. 4. Confirming the diagnosis. And finally, 5. Surgical treatment and recovery.
Starting with part 1, what is a glomus tumor? The origin of the weed.
The number 4, it's surprisingly significant here. Glomus tumors actually have a really stark demographic preference. We're talking a 4-to-1 female-to-male ratio. When you see a glomus tumor, it is overwhelmingly affecting a young or middle-aged woman. Now, maybe 10 to 20% of cases might be tied to broader paraganglioma syndromes, but this 4-to-1 ratio, that's a key piece of demographic data you always want to keep in your back pocket as a primary diagnostic clue.
So what is actually growing in there? Well, these tumors originate from paraganglionic chief cells. These are neuroendocrine cells derived from the neural crest, and their normal, everyday job is basically just to act as chemoreceptors. In the ear, they sit quietly in the adventitia, the outer layer of blood vessels. Specifically, we're talking about the tympanic plexus along the inferior tympanic branch of the ascending pharyngeal artery. When these specific cells go rogue and start to proliferate, they create this highly vascular, very slow-growing mass. It stays localized, so it's non-invasive in the malignant sense, but as it gets bigger, it demands a massive blood supply, effectively turning into a tangled web of vessels.
Moving on to part 2, spotting the reddish-blue mass. Let's look at the clinical features.
Now, what's really interesting about this slide is the visual evidence. When you grab your otoscope and take a look, this is exactly what you're hunting for. A reddish-blue vascular mass lurking right behind an intact tympanic membrane. Sometimes it might even cast a brownish or bluish hue on the promontory. And because this mass is physically getting in the way of the mechanics of the middle ear, literally engulfing the ossicles or the tympanic membrane itself, your patients are almost always going to present with conductive hearing loss. You add that physical blockage to the rhythmic blood flow rushing through that tangled vascular web we just talked about, and boom, you get that hallmark symptom, pulsatile tinnitus, which shows up in 90 to 100% of these cases. You might also hear patients complain of oral fullness, maybe a dull aching pain, or in those rare cases where it's really grown extensively, vertigo or even facial nerve paresis.
Which brings us to part 3, mapping the tumor's spread using the Finch classification.
And this brilliantly illustrates how we categorize that spread. We use the Fish classification, which is essentially a logical, progressive map of destruction. Stage A is your best-case scenario. The tumor is entirely confined to the middle ear. Stage B means it's limited to the mastoid area. Stage C, that's where things start getting quite a bit more complex, involving both the middle ear and the mastoid. And finally, stage D is the big one, the most advanced stage, where the tumor has aggressively extended completely beyond the middle ear and mastoid. Knowing exactly which stage you're dealing with is absolutely crucial for sure, because it is going to dictate our entire surgical approach later on.
Next up, part 4, confirming the diagnosis. Let's look at the clinical funnel.
Let's move to the diagnostic flowchart and see how this builds, kind of like a medical detective story. You start wide at the top of the funnel.
The patient comes in complaining of pulsatile tinnitus and conductive hearing loss. You do your otoscopy, and you spot that reddish-blue mass. All right, suspicion triggered. Next step, we order a high-resolution CT, or HRCT, of the temporal bone. Then we follow that up with an MRI of the temporal bone. Because this tumor is basically a giant knot of blood vessels, we then have to get MR or CT angiography, or digital subtraction angiography, DSA. This officially confirms our glomus tumor diagnosis and hands us the exact vascular blueprint we need to plan our treatment.
Now, you might be wondering, why on earth do we need both a CT and an MRI? Well, think of it like needing two completely different types of maps for a really complicated treasure hunt. The HRCT, that's your hard tissue map. It is fantastic for showing bony erosion, and it's literally essential for surgical planning because it shows you exactly what bone this tumor has already eaten through. But the MRI of the temporal bone, that is the gold standard. It's your soft tissue map. It shows the mass intensely enhancing after contrast, but far more importantly, it defines exactly where this tumor sits in relation to critical, super delicate structures like the facial nerve, the inner ear, and the jugular bulb. You absolutely have to have both of these maps in your hands before you even think about going into surgery.
Finally, Part 5, Surgical Treatment and Recovery, Pulling the Weed.
So, surgical excision is the treatment of choice here. But remember, this tumor is essentially a bleeding sponge. If you just went in and cut into it, the blood loss would be catastrophic. So what do? We do preoperative embolization. We intentionally go in and block off the tumor's feeding vessels beforehand to shrink it down and drastically reduce bleeding. Turn off the tap, essentially. Then, based entirely on the fish classification we walked through earlier, we pick our approach. We might use an endocameral approach for stages A and B, posterocameral for stage C, or the much more complex infratemporal approach for stage D. The surgeon elevates the tympanomeatal flap, ligates the feeding vessels, and then performs a highly delicate, incredibly careful excision. The ultimate goal? Get the whole tumor out while perfectly preserving the ossicles, the inner ear structures, and that ever-so-crucial facial nerve. And afterward, if the tympanic membrane took a hit, we reconstruct it.
Following the surgery, the patient is going to need regular follow-up and audiological evaluations. But the good news here? The prognosis is generally excellent after complete excision. The recurrence rate is really quite low, sitting at less than 10%, and true malignant change is extremely rare. That being said, as clinicians, we always have to be objective about the risks. Potential complications, either from the surgery itself or from the tumor's prior growth, can include facial nerve palsy, sensory neural hearing loss, vertigo, and, very rarely, CSF leaks. But with precise mapping and careful excision, the whole point is to avoid these entirely.
So, the crucial point is perfectly summarized right here in this core takeaway from DHINGRA's standard text on the subject. Glomus tumor should be suspected in any case of pulsatile tinnitus with reddish-blue mass in middle ear. Imaging defines extent, surgery is curative. It is just a beautiful, concise summary of exactly how we spot, diagnose, and defeat this pathology.
As we wrap up this explainer today, I just want to leave you with this one thought. We've gone through the maps, the scans, the surgical strategies, the whole shebang. But take a step back for a second and just consider the sheer complexity of human pathology. How does a tiny, perfectly quiet cluster of chemoreceptors, cells that were designed just to sit there and monitor our blood, transform into this tangled, pulsing mass that literally echoes your own heartbeat back into your ear? It really is a testament to both the fragility and the absolute fascinating complexity of the human body. Thank you so much for joining me on this clinical journey today. Keep questioning, keep learning, and I'll see you in the next